Hello, I'm Ewan Forrest, a consultant hepatologist based at Glasgow Royal Infirmary. I'd like to thank the organisers for this opportunity to speak today. This is my conflict of interest. I've been asked to talk on the subject of alcoholic liver disease, and immediately I probably have to have a little bit of a quibble with this title. I think there's an increasing feeling that the term alcoholic is a bit pejorative, and there's a move towards using other terms. In the States, they're quite keen on alcohol-associated liver disease, and whilst I can see the rationale for that, again, I still think that's maybe a little bit inappropriate or inaccurate, in that it seems to create a little bit more of a distance from the cause of this injury, the alcohol, from its consequence. So the preferred term I would use is alcohol-related liver disease. I tend to ask my relatives to Christmas dinner. I don't ask my associates. And I think it is more indicative of the direct role of alcohol here, even if it's not as pejorative as the term alcoholic. The pathophysiology of alcohol-related liver disease is somewhat complicated. Indeed, if you type this very question into a search engine, this is what you get. And to be honest with you, I think this is not an unreasonable summary of the situation. The pathophysiology of alcohol-related liver disease is incompletely understood. You can download numerous pictures and diagrams that will show flows of events cascading from alcohol use, leading to what seems to be the inevitable consequence of alcohol-related liver injury. There are certainly multiple complex mechanisms, but I would question that idea that it's somehow inevitable, because we know clinically that that's not the case. We know that the majority of people who are drinking too much, possibly even up to nearly 100%, will develop hepatic steatosis. That almost seems like an inevitable aspect of excess alcohol on the liver. But it's only a minority of people who will develop more significant liver injury. Maybe up to 20% will develop cirrhosis, maybe up to just 35% will develop evidence of advanced fibrosis and steatohepatitis. So what factors do affect the development of significant alcohol-related liver injury beyond steatosis? Well, it wouldn't surprise you that dose is important. Several studies clearly indicate that the more you drink, the greater the relative risk of developing cirrhosis later in life. Duration is also important, and this is an interesting study which looked at over 43,000 conscripts in Sweden and looked at their drinking behavior in their late teens and followed them through for nearly up to 40 years. And those who were drinking more in their early life were much more likely to have episodes of severe liver disease later on in life. So duration of alcohol use is important, as well as actual dose at any one time. Other factors that we maybe don't have quite so much control over would be our genetics. And there are several twin studies, but this one here shows a clear excess of the prevalence of both alcohol use disorder and in particular cirrhosis between monozygotic twins compared with dizygotic twins. And you can take this further and you can look at genome-wide association studies and identify certain polymorphisms which are either associated with a greater risk of alcohol-related liver injury, or, on the other hand, a protection against such injury. PNPLE3 and MBOT7 being some of the more common ones that are cited in this context. But dose, duration, and genetics do not account for what is called the alcohol harm paradox. And that's the observation that once you take into account age, gender, type of alcohol, the pattern of alcohol drinking, BMI, smoking status, once you take those factors into account and control for them, the least deprived of people in our society have a much lower risk of alcohol-related harm than the most deprived. And as you can see in this study here, a more than twofold increased risk of admissions to hospital with alcohol-related problems or deaths through alcohol in the most deprived quintile as opposed to the least deprived quintile. And in this graph here, again, you can see that the most deprived 40% of society have a much higher probability of an alcohol attributable event as opposed to the least deprived 60%. So there's some factor here beyond dose, duration, and even genetics. Now, I'm not going to go into this in too much detail. Clearly, alcohol use and excess is fundamental. It has a direct effect on oxidative stress through its metabolism. It produces acetyl coenzyme A, which leads to acetylation with subsequent epigenetic effects. It has an effect upon intestinal permeability with increased gut translocation and also affecting the gut microbiome. And these factors lead to a degree of endotoxemia from the gut translocation. That provides an inflammatory stimulus, the oxidative stress similarly so, and the epigenetic effects give you a pro-inflammatory environment. However, other things affect this, and diet in particular is markedly impactful as far as this is concerned as an effect on microbiome. It has its own epigenetic effects, particularly methylation of DNA and histones, particularly if you're deficient in vitamin B6, folic acid, betaine. It also can create its own oxidative stress. And excess alcohol often leads to compromises as far as diet's concerned. And we also know that socioeconomic status has an impact upon diet, but actually seems to affect the gut microbiome separate from any obvious nutritional deficiencies. So there are factors here. And what I want to emphasize is that whilst alcohol excess and its metabolism is fundamental to the alcohol-related liver injury, there are other factors here which modify the impact of that. Diet, socioeconomic status, gut microbiome, and these are potentially modifiable factors. However, undoubtedly, some people do go on to develop much more significant liver injury. And the next question is, well, how do we identify this early? Because clearly the sooner any such injury is identified, the more that can be done to prevent subsequent morbidity and mortality. Well, this is a quote from this guidance from the Scottish Health Action on Alcohol Problems, the SHAAP group. Men drinking more than 50 units per week and women who are drinking over 35 units per week should have blood tests for liver function, but also have what are described as a non-invasive liver fibrosis test. And that begs the question, well, what do we mean by a non-invasive liver fibrosis test? Well, we can look at standard liver blood tests and use them and manipulate them to come up with composite scores, the FIB4 index, the APRI being the most common ones, FIB4 having a rule-out cutoff of 1.45 or a rule-in cutoff of 3.45 with reasonable negative and positive predictive values. You can do more specialized blood tests, so the ELF test, the Enhanced Liver Fibrosis test, the FIBRA test. In the UK, it's probably the ELF test that's probably most likely to be used, looking at hyaluronic acid, P3NP, and TIMP1. And that can give a clear indications whether fibrosis is present or not. The other non-invasive test of liver fibrosis, which is often discussed, is liver stiffness measurement, liver or transient elastography, or often using the FibroScan. And it does correlate well with liver fibrosis. This is a diagram from the recent Baveno 7 conference, and Maya Taylor, who advocated this, described the rule of 5. If you're less than 5 and 5 to 10, you get very low levels of chance of significant liver fibrosis. Beyond 10, you have progressive risk of significant fibrosis, increased risk of clinically significant portal hypertension, and an increased incidence of liver-related events. We have to remember, however, that liver stiffness is just that. It's not liver fibrosis, and it can be influenced by other factors such as inflammation, cholestasis, hepatic congestion, alcohol consumption. All of these may influence the liver stiffness measurement. And particularly when it comes to inflammation, there is the thought that we should have AST adapted cutoffs, such that if you have a normal AST, a liver stiffness of maybe more than 12 is indicative of F4 fibrosis, cirrhosis, whereas if you had an AST of 300, you may be actually looking for a liver stiffness value of more than 40 before you can be confident that you're dealing with cirrhosis. So some variability in interpretation is required potentially in people who are actively drinking or who have active inflammation. The group of patients we're talking about assessing here are those who don't have any overt evidence of alcohol-related liver disease. They're patients often who have alcohol use disorder. And I want to present a couple of bits of data which relate to this group. The first one is from Freya Rhodes, who's just been awarded her PhD in London. She looked at 99 patients presented to the Royal Free Hospital and did the ELF test. And with the ELF test, she found that just over 28% had evidence of significant fibrosis of the high ELF test. And interestingly enough, in this particular cohort, the ELF test was not influenced particularly by the AST, and therefore it suggests that perhaps the ELF is not affected in the same way as the FibroScan in that context. But I do want to point out this French study, which is very interesting. 259 patients, all of whom did have a raised AST, were biopsied and fibroscanned in the context of active or recent alcohol withdrawal. And what they found was that if you had a liver stiffness of less than 10, you could rule out advanced fibrosis with 99% negative predictive value. If your liver stiffness was more than 25, you could rule in significant advanced liver disease with a positive predictive value of 93%, which actually it gives you very good clinical sort of framework for identifying these people, even in the context of a raised AST and even in the context of recent alcohol ingestion. This obviously leaves a gray zone of 17% of patients who were between 10 and 25. And in the study, they went on and repeated their FibroScan 1 and 2 months later and were able to differentiate those who had more advanced liver disease on the basis of their subsequent FibroScans over time. So it does look as if it is feasible to use either the ELF or the FibroScan in the context of patients with actively drinking with alcohol use disorder, not known to have alcohol-related liver disease. If we put them all head to head, again, Mayatela came up with this study a few years ago, 289 patients biopsied, just over 50% were abstinent at the time of assessment. And as you can see, the ELF and the FibroScan generally outperformed the FIB-4 and the APRI score. You could argue that the FibroScan just had the edge on the ELF test with regards to identifying patients with more than F3 or F4 fibrosis, with fewer false positive and fewer false negative results. So maybe the FibroScan just has the edge in this study. But I want you to think just a little bit beyond these non-invasive markers of fibrosis, because really what we've been talking about so far is, do these tests tell us how scarred the liver is? Really what we should be asking is not how scarred the liver is, but do these tests tell us whether somebody is going to encounter significant liver-related morbidity? And again, from the Danish group, they looked at 462 patients. 20% had advanced fibrosis, all had some degree of alcohol-related liver injury. And they looked at the prevalence, or rather the subsequent incidence of liver-related events, alcohol-related hepatitis, ascites, variceal bleeding, encephalopathy, the standard reasons why people might present with advanced liver disease. And what they found was that whether they used biopsy using the Kleiner fibrosis score, transient elastography, or the ELF test, they were able to differentiate patients into 3 groups with low, intermediate, or high risk of liver-related events, following patients up for up to 7.5 years. And this indicates that rather than regarding these tests as non-invasive tests of fibrosis, we should actually be thinking of them as non-invasive tests of liver prognosis. And rather than using them as simple diagnostic tools, we should be looking at them now as prognostic in their own right and not merely surrogates of liver fibrosis. However, despite all these opportunities to detect people with early disease, patients do present to hospital with advanced liver disease, and the Lancet Commission recently, or in the recent past, indicated that actually not that many patients achieved or were given optimal care for their alcohol-related liver disease. This study was largely in England, and they noticed that the highest death rate from alcohol-related liver disease was in the northwest of England. In this context, this is an interesting study which looked at 7 acute hospitals in the northwest of England. And they looked at 2 time periods, 2014-15, and compared it with a subsequent time period, 2017 and 18. And in the first time period, they identified that 3 hospitals had mortality rates significantly above the average. What was interesting was that after the introduction of quality improvement measures, these 3 hospitals brought their mortality down dramatically. And in fact, all the hospitals were within the appropriate range for the SMR. So what did they do, or what measures were in place that made a difference? Well, those who had high mortality were more likely, or rather less likely, I should say, to screen for alcohol misuse within 4 hours of hospital admission. They were less likely to provide antibiotics and terlipressin within 4 hours of a varicose bleed. They were less likely to provide Pabrinex within 6 hours of hospital admission. They were less likely to perform an early acidic tap, and they were less likely to measure serum lactate. And essentially what this tells us is that if we implement what is essentially good basic clinical care at a sort of early stage in these patients' admission, we can subsequently make a substantial difference to these patients' outcome. And in this context, I would strongly advocate, if you're not using it already, the Cirrhosis Care Bundle, brought out by the BSG in Basel. I'm sure the local hospitals will have their own local version of this, but the application of good basic clinical care within those first 24 hours does have a substantial impact upon the prognosis of patients with alcohol-related liver disease. We need to be really strong advocates for this. One of the issues that sometimes causes a bit of uncertainty is how to manage alcohol withdrawal in the context of alcohol-related liver disease. The mainstay of alcohol withdrawal treatment are benzodiazepines, usually Librium or clonazepam or diazepam. The problem is that these drugs have to go through 2 stages of metabolism till they get to inactive metabolites, and there is clear evidence that in patients with cirrhosis, there is quite disturbed pharmacokinetics with a much prolonged half-life with the risk of accumulation of active metabolites. Whereas shorter-acting benzodiazepines, particularly lorazepam, perhaps oxazepam, their half-life is not affected by the presence of cirrhosis. So it would appear that patients who have advanced liver disease should be given these shorter-acting benzodiazepines. So we in Glasgow use what's called the Glasgow Modified Alcohol Withdrawal Score, which is simpler to use than the CIWA score as a symptom-triggered treatment. We use diazepam as the mainstay of our treatment for alcohol withdrawal, but with the caveat that patients with liver disease, especially jaundice or encephalopathy, we advise using lorazepam only in a symptom-triggered fashion, not in a fixed dose regime, and using 1 to 2 milligrams at any one time. Does it work? Well, recently we audited our own practice, 114 patients with known alcohol-related liver disease or presenting with decompensated liver disease or alcoholic hepatitis, all of whom had been using alcohol within a week and all with a high FAST score, a FAST score being a derivative of the audit score indicating an alcohol use disorder. These patients had a range of severity of liver disease, mild range between 6 and 38. What was interesting was there was a polarization of the need for benzodiazepines. About a quarter didn't need any benzodiazepines at all to manage their alcohol withdrawal, whereas at the other extreme, about another quarter had what would be described as severe alcohol withdrawal, requiring 80 milligrams of diazepam equivalent benzodiazepine on any one day, and or the need for parenteral sedation. The severity of liver disease did not dictate the need for benzodiazepines, and only the initial symptom score, as defined by the GMOS, the Glasgow Modified Alcohol Withdrawal Score, that was the only significant predictor of the likelihood of needing more benzodiazepines. So it is possible to manage alcohol withdrawal effectively and safely in these patients, even with advanced liver disease. But what about that particular manifestation of alcohol-related liver disease, alcoholic hepatitis? The term alcoholic still seems to hang in there with this particular syndrome. It can be defined clinically onset of jaundice within 8 weeks, ongoing alcohol consumption within 60 days, compatible biochemistry with a high AST to ALT ratio, and both values less than 400. In this definition, which is an American definition, they suggest a total bilirubin of 3 milligrams per deciliter, which is about 50 micromoles per liter. I think this is actually far too low and would suggest in American units 5 milligrams per deciliter, and I suppose from the UK point of view, certainly over 80, 85 micromoles per liter. I think a threshold of 50 micromoles per liter is far too, far too sensitive and not specific enough. Clearly, there is the risk of confounding factors, ischemic hepatitis, drug-induced liver injury, or atypical laboratory tests, and biopsy may be required in that context. But generally speaking, most patients can be managed with a diagnosis of probable alcoholic hepatitis. That's diagnosis, but what about prognosis? The discriminant function has been used for a long time, looking at the prothrombin time and the bilirubin. We obviously would advocate the Glasgow Alcoholic Hepatitis Score, a categorical score using age, total white cell count, urea, prothrombin ratio, or INR, and bilirubin, giving a score of 1, 2, or 3 for the latter two variables, and a total value between 5 and 12. I would say we have published a modification of this relatively recently, whereas instead of total white cell count, we looked at the neutrophil to lymphocyte ratio, a score of 1 if the NLR was less than 5, and a score of 2 if the NLR was greater than or equal to 5. There's also the MELD score, and generally speaking, people use the UNOS MELD score pre-2016 equation. The MELD sodium has also been used, and there's also the ABIC score, which looks at age, bilirubin, INR, and creatinine. So there are lots of scores out there. The important thing, I suppose, to know is that recent analysis has indicated that the discriminant function, at the very least, has been totally surpassed by these other scores. Although it was a game-changing prognostic score in its time, it's probably had its day. In this particular study, which is just out, over 3,000 patients, including patients from the STOPA trial, it put the MELD score as having, or MELD sodium score as having, the highest area under the curve, significantly greater than the discriminant function, and the ABIC score, although not significantly different from the Glasgow Alcoholic Hepatitis score. We looked at a subgroup of patients from the STOPA trial, and particularly calculated their modified GAS, that's the Glasgow score with the NLR rather than total white cell count. And what we found in this group of patients was that the area under the curve for the modified Glasgow Alcoholic Hepatitis score was superior not only to the discriminant function, but also to the MELD score and also to the original GAS score using total white cell count. So we do have good prognostic scores. MELD score there's a degree of groundswell for using that internationally, but in fact, the data would suggest that the Glasgow score is equal and the modified Glasgow Alcoholic Hepatitis score is perhaps superior. I mentioned the STOPA trial. This is the largest alcoholic hepatitis study performed in the UK on the standard Kaplan-Meier analysis. The steroid-treated patients were just not quite significantly more likely to be alive at 28 days, but in multivariate analysis, treatment with prednisolone was associated with a reduced risk of death. And when the STOPA data was added into 10 other trials, it was concluded that survival at 28 days was significantly reduced with corticosteroids, although any benefit was lost by 6 months, and certainly in the STOPA data, that benefit was also lost earlier at 90 days. So short-term survival benefit was evident, or is evident, from prednisolone treatment in these studies. The thing we have to remember is that all these studies use the discriminant function as the threshold for inclusion. And as we've already seen, that's maybe not the optimal score. So the question is, can we use other baseline scores to predict response to prednisolone? Well, again, a study just out, just over 3,000 patients, just over 1,200 of whom received corticosteroids. And this study suggested that only patients who have a MELD score more than 21, less than 51, were going to benefit from steroids. Less than 21, there was no significant benefit. More than 51, there was probably a degree of futility. I have a few problems with this study, I must admit. It was a retrospective, non-randomized study. We know that the decision to use steroids or not use steroids in these 1,200 patients is very much influenced by factors not encompassed by the MELD score. Physician belief and prejudice has a big influence here. And I must say, I'm slightly concerned about such a large, it's good it's a large cohort, but the fact it's non-randomized means there are a lot of potential confounders here. The STOPPER trial does have the advantage of having just over 1,000 patients, all of whom were randomized, and therefore hopefully were equitably distributed between the treatment group or not. What was interesting about this is if we look at those who have consistently low scores, those who have got a low Glasgow alcoholic hepatitis score of less than 9, there was no benefit to taking steroids. There was no benefit if the MELD score was less than 25. But interestingly enough, in the small number of patients who had a MELD score less than 21, there was perhaps a marginal survival improvement with steroids. Now, I don't want to put too much emphasis on this because the number of patients with a low MELD in STOPPER were very, very small. But the very fact that there's any suggestion of difference here implies that perhaps the observation from this more recent study is not entirely correct, as this would suggest that the patients with a MELD score less than 21, some of them may yet derive benefit from prednisolone, which wasn't seen in the above study. If we look at those patients with high scores, again, if we look at the range of patients similar to those who are felt to benefit according to this recent publication, there was no statistically significant improvement in outcome at 28 days for these patients. The only patients who did benefit to 28 days were those with a Glasgow alcoholic hepatitis score greater than or equal to 9. So I would suggest that if you're going to use a baseline score to predict who's likely to respond to prednisolone, that at the moment, the evidence would be in favor of using the Glasgow alcoholic hepatitis score with a score of greater than or equal to 9. There are, of course, other scores out there. There are what are called dynamic scores, which look at corticosteroid response when these treatments are used for alcoholic hepatitis, looking at change in bilirubin. But the Lille score probably is the most commonly used one. Classically, it's the Lille score calculated at day 7, where those with a high Lille score have a very poor survival. Those with a low Lille score have a better survival, although there's increasing evidence that you can actually calculate the Lille score after just 4 days of prednisolone and again get a similar clinically useful separation. So if we distill all this together, how do we approach alcoholic hepatitis from a treatment point of view? Well, this is from the EASL guidelines. They suggest a clinical diagnosis is possible, liver biopsy if there's diagnostic uncertainty, consider giving them nutritional support, look for and treat infection, and then assess with prognostic scores. Now, they suggest a discriminant function or the Glasgow score. Let's make this easy and just get rid of the discriminant function. And if we do that, 50 to 60% will have a low Glasgow score and therefore require no specific therapy. If we treat the remainder, 20 to 25% will have a favorable Lille score and should continue their steroids for 28 days. However, 20 to 30% will have an unfavorable Lille score. And it's suggested that these patients should stop their prednisolone. And in this particular guideline suggests we should consider liver transplantation, which is not currently an option in the United Kingdom. But this is the advanced course, and I want you to take you a little bit beyond this, beyond that pathway, and think about the trajectory of alcoholic hepatitis. People present with alcoholic hepatitis at different stages in their disease. Some, the bilirubin is escalating, in others, it's falling. And Richard Parker from Leeds looked at this study and identified those who were fast fallers within 7 days, those who were static, and those who were rapid risers with regards to their bilirubin. What he found was that those fast fallers were more likely to be alive at 90 days, 79% survival, and there was no evidence that giving them corticosteroids made any difference to their outcome. So if you identify somebody who's a fast faller, you can perhaps avoid exposing them to corticosteroids as they have a favorable outcome anyway. However, we don't always have the luxury of waiting 7 days to see how things are going. And the question is, can we identify this trajectory earlier? What is quite clear is that we can't identify any change in bilirubin earlier than day 7. Richard Parker found that, and indeed we also found that when we looked in detail at STOPA patients in Scotland. What we did find in the STOPA patients, however, was that a change in composite prognostic scores between admission and day 3 or day 4 was associated with subsequent outcome. And by composite prognostic scores, I'm meaning basically the Glasgow score or the MELD score. And if these were static or rising, then their outcome was much reduced, their survival was much reduced at 90 days compared with those who had a falling value. I also want to introduce you to the concept of theragnosis. And again, bringing in this value, the neutrophil to lymphocyte ratio. And theragnosis really is trying to not so much predict prognosis, but predict the likelihood of response before exposing the patient to corticosteroids. We know the Lille score is useful at telling us what happens after exposure to corticosteroids. Can we do better at baseline rather than just relying upon baseline prognostic scores? And again, looking at the STOPA cohort and then subsequently validated in more than 300 patients in the UK, we were able to identify that there was a range of neutrophil to lymphocyte ratio that was associated with favorable response to steroids. And that range was between 5 and 8. And as you can see, that beneficial response to corticosteroids was seen at 28 days, but also at 90 days. If the NLR was less than that, less than 5, or greater than that, greater than 8, corticosteroids had no significant impact upon outcome. So I want to now take you to an advanced approach to alcoholic hepatitis. Yes, we can make a clinical diagnosis and consider biopsy, and we need to screen for infection. I would also raise that point we should be very careful with beta blockers and diuretics. We need to preserve these patients' renal function. We need to treat their alcohol use disorder, alcohol withdrawal. We've talked about that, talk about thiamine supplementation, but never forget supplementing their magnesium, which is equally important when it comes to preventing vernicas. I want to highlight here, however, the importance of evaluating nutritional status. This isn't just an afterthought or a sort of a sort of minor concern. We know that getting food into patients, certainly more than 21.5 kilocalories per kilogram per day, is associated with a sustained improvement in survival. And oral route is as effective as the nasogastric route if they can achieve that. And so after giving this nutritional support, we should look at trajectory. And by that, I mean looking at their composite prognostic scores. And if their Glasgow alcoholic hepatitis score or MELD score are improving, then keep an eye on them, watch them. We don't necessarily need to launch in with specific treatment. If, however, those scores are rising or static, we should assess their NLR. And if the NLR is in the sweet spot between 5 and 8, we should give them prednisolone, again, going down the route of assessing Lille response and treating for 28 days if favorable and stopping if not. If the NLR is unfavorable, then again, no specific therapy other than this nutritional support, which is absolutely vital for these patients. So please don't underestimate that. The other thing to consider is where we should be treating them, because we still have very good prognostic scores. I've mentioned the GAS and the modified GAS score. And I think if they have low GAS scores, then we should consider early supported discharge, as long as they have no other significant complications and their attendance at an intensive, often nurse-led clinic is feasible, whereas those with higher prognostic scores may need to remain in hospital to assess their trajectory and need for treatment. So I think this is a more nuanced approach and one which takes into account, I think, some of the most recent evidence to stratify more effectively those patients who should be treated. But here we are talking about specifically alcoholic hepatitis and trying to get them to survive to 28 days, 90 days, maybe 180 days. What about the longer term? And the long-term prognosis of alcohol-related liver disease is ultimately about their alcohol use disorder and the achievement of abstinence. And this is one of the intriguing aspects of alcohol-related liver disease, is that we're really dealing with two problems. We're dealing with the liver injury, but we're also dealing with an alcohol use disorder. And we know that continuing drinking to any degree, even if it's within safety limits, as suggested by the chief medical officers, that is still associated with a worse outcome at 1 year compared with those who are abstinent. So abstinence makes the biggest difference if we want to follow out to 1 year and indeed beyond that to 10 years. How do we achieve this? Well, there are all sorts of psychosocial interventions, brief interventions, motivational interviewing, cognitive behavioral therapy, couples therapy, self-help, peer mentorship, things that I'll be honest with you, I don't understand because I'm not trained as an addiction specialist. And I think we have to work with our addiction specialists. If we're not actually going to, as hepatologists, be actively trained in these methods of managing our patients, then we have to find ways of integrating our clinical care with our addiction specialists. We know that doing so, treating their alcohol use disorder, is associated with a dramatic reduction in hepatic decompensation and an overall reduction in long-term mortality. Yet, and this is data from the States, but I think it probably reflects the UK situation as well, that very few of our patients with alcohol-related cirrhosis actually receive face-to-face addiction specialist input. And in this particular study, less than 1% received an FDA-approved medication for alcohol use disorder. And whilst we're very comfortable with using spironolactone, steroids, and thiamine and such like, we as hepatologists are particularly inexperienced with using drugs to reduce alcohol cravings. We are unfamiliar with disulfiram. When do we use that as opposed to acamprosate? Is there a role for baclofen? And these are important questions that we need to address as hepatologists if we want to look at or help our patients in the long term. I will point you in the direction of an article that's just come out in the Lancet Gastroenterology and Hepatology, which looks at this very precise issue of the barriers to an integrated model of care, integrating clinical hepatology and addiction services. And I think I think this is one of the major challenges for alcohol-related liver disease. We should be looking at ways of trying to ensure that we'll work closely together, or addiction training becomes an integral part of hepatology training. So that's been a little bit of a run through alcohol-related liver disease. The cause is obvious, it's alcohol, but the damage it causes is not inevitable. And I want to highlight the potential role of diet, socioeconomic status, and the influence upon microbiome and the subsequent liver injury. Early detection of alcohol-related liver disease is feasible, and it's feasible using the tools we have available now. And I'm thinking particularly of the ELF blood tests and FibroScan, and that's applicable for patients who have active alcohol use, who don't necessarily have overt alcohol-related liver disease. Hospital care for alcohol-related liver disease can be improved, and it's really best improved by applying good, effective, simple clinical care. And that's really what the Basel BSG bundle is all about, making sure that the right things happen at the right time. I think we can effectively manage alcohol withdrawal in patients with alcohol-related liver disease using a symptom-triggered approach. We would favor the Glasgow modified alcohol withdrawal score using lorazepam or other short-acting benzodiazepines. The diagnosis of alcohol-related hepatitis is largely a clinical diagnosis. Be very aware of the trajectory of the disease and trying to assess that early. The Glasgow score, the modified Glasgow score, and the MELD score are prognostic, but I would suggest that if you want to identify theragnostic scores, then we should be looking at those with a high Glasgow score, greater than or equal to 9, and an optimal NLR between 5 and 8. And again, just to focus in on the vital nature of addressing these patients' alcohol use disorder and the importance of integrating our clinical hepatology services with addiction services. As I say, that's a brief view of some issues there. I haven't even touched on the role of transplantation, particularly in the context of alcoholic hepatitis. I haven't looked at the role of MUP and the impact that's had upon alcohol-related liver disease, or indeed the impact of COVID. So many things that have happened in the last few years. But I think that's enough to be going on with at the moment, I think. And thank you for listening. And I think there's now going to be an opportunity for questions. Thank you.